The following podcast is part of a certified educational activity titled Taking the Leap in MCL, New Opportunities with BTK Inhibitors and Other Innovative Strategies. Access the entire activity and complete the post-test at peerview.com/YEK860. Downloadable slides and practice aids are also available.
Welcoming you for this satellite symposium being organized by PeerView. And this is really focusing on mantle cell lymphoma because a lot of changes have been taken place during the last couple of 3 months. And we do see new opportunities with BTKI. And that is our starting point to really reflect what about the therapeutic algorithm now, considering the very recent data. So what's the status 2023? And I'm really privileged to be joined by really the opinion leaders of the field. And we have with us Cami Maddox from Columbus, Ohio. Cami, good to have you here.
Thank you.
And on the other hand, Toby, Oxford, is that Europe or is that US?
Don't ask that
You
question.
figure out. Anyway, no, they're very knowledgeable. And what we really would like to do, we would guide you through this program. So we have to start with the official label. And right now, it's a little bit bizarre because in the European Union, the only one registered is ibrutinib, whereas that was withdrawn for formal reasons from US. On the other hand, the two other second-generation Acala and Zanu are registered in US, but not in Europe. There are still these phase 3 studies running. And finally, for pirtobrutinib, this has been approved by US after 2 prior lines of therapy, including a BTKI, so essentially a BTKI failure patient, whereas for Europe, EMA has recommended conditional approval, but it's still not yet there. And finally, nemtabrutinib is another candidate of this class of non-covalent BTKI, is currently in phase 2 study. Okay. So this is the official registration status, but we all can speak about whatever we would like to. And of course, we start with guidelines because guidelines, they try to incorporate all the knowledge we have. And luckily, the NCCN guideline just has been updated. And I really would like to refer to the, you might say, consequence of the triangle trial. By the way, the German Austrian Swiss guideline has been also published last week and is also online with the same recommendation. Here it's triangle regimen, which supports the combination of a covalent BTKI with chemotherapy. And that holds up for maintenance. Now, interestingly, this is an evidence level of 2A for ibrutinib, because this is what has been applied in the study, and our American colleagues conclude that it's category 2B for the other BTKI based on the probably comparable efficacy, but we will hear more about that. Good. What about standard of care in relapsed mantle cell lymphoma? And please be aware that is based on the assumption that these patients have received chemotherapy only in first line. And there we have, this is the NCCN, so the American, or better said, the US guideline. So ibrutinib is not represented here, but I would say probably the first pick is really BTKI. So in this setting, Acala and zanubrutinib. Lenalidomide and rituximab is also listed. Please be aware. There is this first line study by our New York colleagues from Weill Medical School. And there's also the option for, and that's based on data by Michael Wong, ibrutinib plus rituximab. In third line, this is somewhat open, depends of course on prior treatment, but our American colleagues recommend non-covalent BTKI. So at that stage, I would guess most patients have been pre-treated with a classical covalent BTKI or CAR T cells. And of course, which way to go, that depends on your health system, on the patient's performance status, of the aggressiveness of the disease, and we will hear more about that. And finally, this is also important, if you want to win something in mantle cell lymphoma, you really have to focus on the first-line treatment, because once the disease is relapsing, it becomes significantly more aggressive, and that's even more pronounced for the POT24 patients, so the early relapses. Here we really have a problem similar to other lymphoma subentities, so there we have to improve before. And now this is especially for patients being pre-treated with BTKI, and you see the slope of the curve even goes further down. So these are really the desperate cases. Now that sets the scenario, what we would like to focus on. So our goal is to improve your understanding of the mechanism, selectivity, but also safety profiles of the different BTKIs. We would like to give you an overview about the evidence supporting the use of BTKI and other innovative targeted approaches across the spectrum of mantle cell lymphoma, doing both first line and relapse. And finally, bring you into the position that you can really evaluate the field and select upfront and sequential treatment. All right, we're all set, let's go. And we called it Masterclass, and therefore we start with Cami, and she will really guide us through the understanding the basics and the current role in relapsed mantle cell lymphoma. Cami, please.
Thank you, Dr. Dreiling. All right, so Bruton's tyrosine kinase, or BTK, is a critical kinase in the B-cell receptor signaling pathway. We know that signaling through the B-cell receptor is important for the growth, proliferation, and survival of normal B-cells, but it's also important for the growth and survival of malignant B-cells. Targeting different kinases in the B-cell receptor, therefore, is of interest for therapeutic value. So Bruton's tyrosine kinase, or BTK inhibitors, there's a number of different oral BTK inhibitors that have been developed. Targeting BTK through these oral BTK inhibitors has shown to be effective in a number of different B-cell malignancies, including in mantle cell lymphoma. Ibrutinib was a first-in-class oral BTK inhibitor. It's an irreversible or covalent inhibitor of BTK. It was the first agent approved in the US and the only agent approved, as Dr. Dreiling mentioned, in the European Union. So ibrutinib, this is the kino mapping for the different BTK inhibitors, and ibrutinib not only targets BTK but has some off-target effects, including inhibition of TEC kinases, ITK, and other kinases, and these off-target effects lead to some of the toxicity profile we see with these agents. After ibrutinib came the development of the second-generation BTK inhibitors, acalabrutinib and zanubrutinib. The second-generation BTK inhibitors, as you can see, are a little more selective for BTK, leading to less off-target effects, which has a difference, leads to the differences in the toxicity profiles that we see. More recently, we've seen the development of reversible BTK inhibitors, or non-covalent BTK inhibitors that bind at a different binding site. These include nemtabrutinib, and probably most recognized as pirtobrutinib, given it has received recent approval and recommendation for approval. These are even more selective for BTK, leading to differences in the toxicity profile of these. So as I mentioned, ibrutinib was the first BTK inhibitor studied and the first BTK inhibitor approved. Ibrutinib's initial approval in the U.S. came through an accelerated approval based on a single-arm phase 2 study that enrolled 111 patients and showed an overall response of close to 70%, with a complete response of 20% and a median PFS of close to 14 months. The approval in other countries came mostly from a randomized phase 3 trial looking at the randomized patients to ibrutinib versus temsirolimus, showing a significant improvement in progression-free survival with ibrutinib. Ibrutinib has been around the longest, and we now have long-term follow-up from ibrutinib studies, including outcomes with patients who've been treated now for close to 10 years. So this slide shows the outcomes of a pooled analysis of 3 different trials that treated patients with single-agent ibrutinib, RAY, SPARK, and the PYCY trial that led to approval in the U.S. So this included a pooled analysis of 370 patients treated across 3 trials. With nearly 10 years of follow-up, we saw that the median progression-free survival was a little over a year, and median overall survival 26.7 months. However, it was noted that when ibrutinib was used in the second line of therapy, that their median progression-free survival was a little over 2 years and median overall survival 5 years. It appeared that ibrutinib patients did best when achieving a complete response to ibrutinib with a median PFS of 5 years and a median overall survival not reached. It was also shown in this pooled analysis that with BTK inhibitors, people that had POD24, which as Martin mentioned is a poor prognostic factor, did better with BTK than with chemoimmunotherapy. And those patients did better with ibrutinib than the last treatment that they had received. The second BTK inhibitor to receive accelerated approval in the U.S. was the second-generation BTK inhibitor acalabrutinib, and this was based on the ACE-LY004 study. This was another single-arm phase 2 trial enrolling 124 patients with a median age of 68 and a median prior 2 therapies. The overall response rate with this agent was 80% with a complete response rate of 40%. We've seen longer follow-up of this phase 2 trial with a median follow-up approaching 40 months. The median progression-free survival was 22 months and median overall survival close to 5 years. The final covalent BTK inhibitor that's been approved in the U.S. is zanubrutinib, and this was also received accelerated approval based on a single-arm phase 2 study enrolling 86 patients with relapsed refractory mantle cell lymphoma. This trial showed an overall response rate of 84% with a complete response rate of 68%, median progression-free survival of 33 months, and median overall survival not reached. I will mention there was a second study looking at zanubrutinib with a smaller number of patients. That was a multi-center study that showed similar overall response rates, although a lower complete response and more similar to what's seen with the acalabrutinib. So while we know that almost all patients with mantle cell lymphoma are going to respond to BTK inhibitors, we know that the majority of patients are also going to become resistant to those therapies and progress. The mechanisms of BTK resistance are overall poorly understood in mantle cell lymphoma. So in CLL, we know that the majority of patients who become resistant to BTK inhibitors will do so by developing mutations in the binding site, the BTK cis481, or mutations in PLC gamma. However, in mantle cell, this is not as well understood. There are reports of a small numbers of patients who develop mutations in these binding sites, but by far the large majority of patients do not develop such resistance mutations. So some of the mechanisms that are thought to drive resistance in mantle cell lymphoma include some mutations in the binding site, activation of bypass pathways, such as PI3 and AKT, and then upregulation on survival signaling from the microenvironment. This just lists some of the different primary resistance mutations and secondary resistance mutations that have been reported in mantle cell, although again, in much smaller numbers and not consistently. It is important for us to be able to further understand resistance to BTK inhibitors because that could play a role in how we better treat these patients, including how we sequence therapies or combination therapies that are able to overcome these resistance mechanisms. All right. Now welcome back, Dr. Dreiling, for moving up front new evidence with frontline BTK.
Okay, so my duty is now to report on the role of BTKI in first line. What is the evidence? And I will start with a company-sponsored trial which is comparing the classical regimen for elderly patients, bendamustine rituximab plus minus ibrutinib. Very much straightforward, multi-center, international trial, and this trial has achieved its primary endpoint as shown here. PFS was significantly improved, and that is extension of the median PFS in the range of 2 point something years. So that's good. However, the other thing was that, and this is here a safety consideration, that what has been observed, patients were not dying of the lymphoma. In fact, if you went to the disease-specific overall survival, then it was improved, but when you took the total overall survival, it was somewhat comparable. Therefore, it was suspected that additional toxicities may add up. And that is reflected also by other numbers. Please remind, the ibrutinib addition was an unlimited treatment, and more patients in the ibrutinib, in the verum arm, did prematurely discontinue treatment in comparison to the placebo arm. We really had a serious look at the different reasons, and there was no clear signal, I have to say, but still the overall frequency of adverse events were higher in the ibrutinib arm. On the other hand, PD or relapse were, as expected by the PFS curve, significantly less frequent in the verum arm. Now, when we look at that and have a look at a similar design for Arcala, and these data have been presented at last ASCO and EHA, so we have a small cohort with 38 patients exploring the same principles. Overall response rate was, in the first line cohort around 94%, then in salvage 85%. Of course, this has to be always considered, taken into account the a priori risk profile of the patients. But it's fair to say, when we look at the overall survival, it looks promising. Now, interestingly, in this small cohort, outcome of relapsed and first-line treatment was similar. Whether this will hold up with within a larger patient cohort and longer follow-up has to be waited for. Anyway, based on these data, the phase 3 trial is similar to the SHINE data, has been now initiated, the ECHO trial, and has been completely recruited, and we are waiting for the results. And that is shown here. What you can see is that it's almost exactly the same as SHINE trial. Patients above the age of 65 years old with, of course, histologically confirmed mantle cell lymphoma and have not been pre-treated for this kind of disease. And again, also in this trial, it's an unlimited BTKI treatment. So we did a similar approach and a different approach, depending on your point of view, because we moved to the younger patients, and this slide nicely represents Europe, because Europe is never speaking with one voice, but with multiple, at least a dozen, and therefore we could not agree on the experimental arm, so we added 2 of them. And one is the classical add-on design, and the other one is the head-to-head comparison, so skipping autologous transplant. And another difference is that we, from the beginning on, went for fixed duration maintenance of 2 years. So after 2 years maintenance, the BTKI was stopped. So let's have a look at the response rates after induction when it comes to overall survival, overall response rate, which in my opinion is the more relevant one. It's improvement from 94 to 98%, So you could say, well, it's only 4%, but in most of our clinical centers, it's hard to get above 100%. So that's why, there's a natural limitation. But for CR rate, the benefit was a little bit more pronounced with plus 9% from 36 to 45%. And both were, of course, statistically significant. Now, what about the primary study aim? And that is here frequent von treatment failure. It highly corresponds to progression-free survival. So there's a difference of a total of whatever 7 patients. So this is somewhat PFS curve. Just to let you know, we analyzed also PFS. And anyway, both of the experimental arms were superior to autologous transplant. And why we expected that for the combination arm, and therefore we outlined the statistics to prove that, and the improvement of 15% PFS after 3 years was highly significant. We had a very complicated statistics for the ibrutinib only arm, but you see by eyeballing it's exactly in the same range as the combined arm, and the same holds up for overall survival. And therefore, definitely autologous transplant only is that if you have the possibility to apply BTKI in your health system. Now the question is, we can turn it around. We can ask, if you have ibrutinib forgiven, what about the addition of transplant? Does it add to that? And at least these curves don't suggest that, but it's very few events so far. What I can share with you, we have a subsequent longer follow-up, and the curves look exactly the same. Now, if efficacy is similar, we also have to look into toxicity. And that is shown here. Here is compared the 3 different study arms, and in the grass green, it's a combination of autologous plus ibrutinib, and in this yellow-orange, it's ibrutinib only. And what you can see is in the combined arm, what you may have expected, hematological toxicity and also infections are significantly higher. So based on that one, we would prefer the ibrutinib only, and in fact that's what we are doing in clinical routine. Only in the cases with additional risk factors, with high Ki67 or so, there we are not sure, and therefore we kept the optional autologous transplant in our current guidelines. And I should also refer to data being presented at this meeting by Michael Wong, the famous Window 2 study, which is starting with a non-chemo approach and then having a high-dose consolidation. It will be interesting to compare the toxicity profile of this approach to our study. So just to move on, is there a role for skipping chemotherapy overall? So we already kicked out autologous. Do we need chemo at all? And just to share with you, there are some data on that, and this are the data again by the Weill Medical Center being presented at last ASH. Now a triple combination, R square plus acalabrutinib, and small study, 24 patients, so this is hypothesis generating, but what you can see, it was well tolerated and overall response rate was rather high. CR impressive as well. Now, the other, I would say everyone's darling, is the combination with venetoclax, and also here we have first phase 2 studies, in this case 21 patients, again by Michael Wong from MD Anderson, and here a quite similar picture. It was well received and response rate was very high. So just to remind you, these are early phase 2 studies. In larger phase 3 studies, this is normal life. Response rates will go down, and but anyway, this is encouraging. Now, our French colleagues went on this and then went for the triple combination, right? And this is ibru combination with venetoclax plus the more efficient anti-CD20 antibody in mantle cell lymphoma, obinutuzumab. And again, these data will be updated. We've seen them at EHA, and they look quite encouraging. And again, based on this one, OASIS 2 has been activated, and this is a randomized trial really comparing this triple combination in comparison to a doublet, ibrutinib and anti-CD20 antibody only. And finally, and that is, I think, the core question, of course, at the end of the day, we have to ask, is it better than our current stance? Is it better than chemotherapy? And we have two studies addressing that. The one is the British ENRICH trial, and Toby may comment on that in more detail, but it's fully completed with 300-something patients, and we're waiting for the final readout comparing RI versus our chemotherapy, either CHOP or bendamustine. And we have just started this study. First patients being recruited for now. Oh no, this is another one. This is the Beijing study, and that's similar to the first two company-sponsored trials. Compares BR versus now again head-to-head IR, and that will be very interesting. So this is a huge study with 500 patients, close to full recruitment, and these data are eagerly be awaited. And here I hand over to Toby. Toby will allude us what happens once BTKI fail, and what can we do then with, for example, non-covalent BTKI.
Thank you very much, Martin. So as you can see, covalent BTK inhibitors are being extensively investigated in the frontline setting. Of course, that will naturally open up a much larger space in the sort of post-covalent BTK area. And there are a number of agents in development here. I've just got time to really touch on three that are probably the most prominent in the most in the greatest kind of degree of development. So the first one has been alluded to already. So pirtobrutinib is a highly selective non-covalent BTK inhibitor. It's a reversible BTK inhibitor and has very favorable pharmacokinetics with BTK inhibition across the 24-hour dosing cycle. It's a once daily, well-tolerated tablet that's been investigated in the phase 1/2 Bruin study, as you can see here. So this is data from ASH21, actually, 618 patients. You can see here in the phase 1/2 study. It's actually up to 773, I think, now. Lots of CLL patients in there, a number of other interesting histologies, but also comfortably over 100 mantle cell lymphoma patients. We saw data on these 111 that were efficacy evaluable at the last year's ASH, but most recently we've seen the pivotal data set, which has led to the approval of this agent in 90 patients that had adequate follow-up. So you can see here there was a median follow-up of a year here. These are the basic response data. This is a heavily pretreated patient population, median of 3 prior lines. Nearly all had received immunochemotherapy, including CD20 antibody, and also all had received a prior covalent BTK inhibitor. Nearly the vast majority having been failed by the covalent BTK inhibitor because of progressive disease rather than intolerance. And you can see here the overall response rate of nearly 60% with a CR rate in 20% in this pre-treated population. There was a smaller sub-study of covalent BTK naive patients where 14 patients were treated, and you can see here very high response rates with a CR rate of 35% in that cohort. Here's the duration of response and the progression-free survival overall. So if you just focus on progression-free survival, first of all, you can see 40% of patients don't respond, so you get a sharp drop-off of the progression-free survival curve. But actually, interestingly, you see quite a few patients with very durable responses, and that's really reflected by the duration of response. So one of the very interesting things about this agent is clearly there are patients who are still very sensitive to very highly specific BTK inhibition in this setting. And actually, a median duration of response of nearly 22 months in that setting is very noteworthy. So this agent's been, as mentioned, recently FDA approved in relapsed refractory mantle cell lymphoma, 2 prior lines or more, including a covalent BTK inhibitor. We're yet to hear about European approval, hopefully fairly soon. Following on from this, the randomized phase 3 Bruin 321 study is currently ongoing, enrolling, and is challenging covalent BTK inhibition in relapsed refractory mantle cell lymphoma head-to-head. So this is taking patients who have received at least one prior line of therapy, have adequate performance status and reasonable blood counts, and they are stratified according to their simplified MIPI score, the intended BTK comparator, and the number of prior lines of therapy. And you can see here, it's a permissive study, and it's in the control arm in that investigator choice covalent BTK inhibitor can be used. And that's really to take into account the fact this is a global study with, as Martin has mentioned, different covalent BTK inhibitors being available in different nations. This is a superiority design, 500 patients in this study, and it's enrolling well at present. So kind of watch this space for this study in the next couple of years or so. So moving from a single once-a-day oral tablet to CAR T-cell therapy, clearly very different in their delivery. Anti-CD19 CAR T-cell therapy is a highly effective therapy in relapsed refractory mantle cell lymphoma. I'm sure we're all aware of this data from ZUMA-2, just under 70 patients, heavily pre-treated, as you can see here, median again of 3 prior lines of therapy. Many patients have had prior ibrutinib, some more than one BTK inhibitor, and they had high-risk clinical and biological characteristics. And really, at the time of this initial publication, standout response rates over 90%, and the CR rate, just remember this, 67%. We'll come back to that in a minute. These responses are generally durable, particularly the complete responses. We've seen updated data in the JCO fairly recently, showing that those who obtain a complete remission, so those 2/3 of patients having a median PFS of 48 months. And we can all debate, it's a shame there isn't a vote on this, whether these patients are cured or not. I think time will tell. But you can see here, if you take the whole population as a whole, median PFS of nearly 26 months. But as Cami will talk about later, this comes with toxicity. So a third of patients having grade 3 or more neurological toxicity. For those of you who have treated patients with CAR T-cell therapy, you'll recognize that there's a substantial toxicity consideration. Most patients develop cytokine release syndrome, with about 15% or so from this trial developing grade 3 or worse cytokine release syndrome. So there are relevant toxicities, and clearly there are manufacturing considerations and socioeconomic and delivery considerations with CAR T-cell therapy. And just finally, the third treatment modality I want to discuss briefly is other bispecific antibodies. Many of you, no doubt, will be very familiar with glofitamab from its data, particularly in diffuse large B-cell lymphoma that we've seen prominently presented and published over recent times. This is a CD20, CD3 bispecific antibody. CD20 very strongly expressed in mantle cell lymphoma, of course, and that may be a very relevant point moving forward in terms of its development. This agent has been investigated as monotherapy with various step-up dosing in the initial phase 1/2 study, and also with different doses of obinutuzumab to debulk patients before the delivery of the glofitamab. So far, we've seen updated data at ASH last year, 37 patients, 2/3 approximately of which have received a prior covalent BTK inhibitor. As mentioned, a couple of different dosing strategies of obinutuzumab have been investigated, really to look at both efficacy and also potentially mitigating cytokine release syndrome. The response rate overall in the whole 37 patients is here, so 84%. CR rate in this population, including the third of patients that hadn't had a prior covalent BTK inhibitor, 73%. Unfortunately, I don't have the slide of those that have had a prior covalent BTK inhibitor, but I can tell you the CR rate is identical to CAR T-cell therapy, so 67%. And although follow-up in this study is pretty short at the moment, the median duration of complete remission has been reached at 10 months, but there are actually 4 COVID-related deaths in this study, which I think has made this Kaplan-Meier curve slightly difficult to interpret. I think probably what's more relevant right now is that 20 out of the 27 do remain in a complete remission at the data cutoff. So I think we clearly need longer follow-up and more patients here. But off the back of this data so far, there is going to be a randomized clinical trial, which is sort of in setup at the moment in BTK-exposed CAR-T naive patients with glofitamab. So this agent is being actively developed further in mantle cell lymphoma. And bring back Cami to stage. Cami's going to talk around safety of some of these newer agents in mantle cell lymphoma. So thank you for your attention.
All right. So we've heard a lot about efficacy, but now we'll transition to safety and toxicity profiles, which can be just as important as the efficacy. So we have no head-to-head data or randomized data in mantle cell lymphoma looking at the different covalent BTK inhibitors. As Toby mentioned, there is the ongoing Bruin trial, which will randomize patients to covalent versus non-covalent BTK inhibitor to better evaluate both efficacy and toxicity. But at this time, we only have the data from the single-arm phase 2 trials. Now, while we don't like to compare single-arm phase 2 trials against each other, this slide does just depict some of the grade 3 or higher adverse events of interest seen in all of the single-arm phase 2 trials that led to the approval of the different covalent BTK inhibitors, ibrutinib, acalabrutinib, and zanubrutinib, specifically differences in neutropenia, major hemorrhage, and atrial fibrillation. I think it's also important to note that part of the difficulty with comparing across trials is that these can have different populations of patients. And so this slide also does show the variability in the patient populations that's treated on these trials by median prior lines of therapy and median age. So if you look overall, rate of discontinuation due to adverse events, 7%, 6%, and 9.3%. So while we have no randomized data for efficacy or toxicity in relapsed refractory mantle cell lymphoma, we do have randomized data in other diseases comparing covalent BTK to other covalent BTK inhibitors. And I think we can at least look at this data to extrapolate for what we're likely to see in patients with mantle cell lymphoma. So we have 3 large randomized phase 3 trials evaluating covalent BTK versus covalent BTK, 2 in chronic lymphocytic leukemia and 1 in Waldenstrom's. So the first trial I'll mention is the Elevate-RR trial, and this was a trial evaluating patients with relapsed refractory CLL and randomizing them to treatment with ibrutinib or acalabrutinib. At a median follow-up of 40.9 months, these are the toxicity differences between toxicities of interest, including the atrial flutter, AFib, hypertension, and bleeding. You can see that there was a higher incidence of all 3 of these with ibrutinib compared to what was seen with acalabrutinib. And additionally, there was lower cumulative incidence of diarrhea and arthralgia as well. Looking at rate of treatment discontinuation because of adverse events, it was 14.7 with acalabrutinib versus 21.3 with ibrutinib. The second trial was also conducted in relapsed refractory CLL, and this was the Alpine study. So this looks at the incidence of atrial fibrillation, flutter, hypertension, and hemorrhage in relapsed refractory patients with CLL randomized to ibrutinib versus zanubrutinib. This has a little bit shorter median follow-up, but a median follow-up of close to 30 months. There was a higher incidence of atrial fibrillation or flutter with ibrutinib compared to zanubrutinib, but rates of hypertension and hemorrhage were overall similar. Treatment discontinuation in this trial included 15% of patients discontinuing from AEs with zanubrutinib and 22% with ibrutinib. The last randomized trial was the Aspen trial, and this was conducted in patients with relapsed refractory Waldenstrom's. Again, these patients were randomized to covalent BTK with ibrutinib or with zanubrutinib. This was reported after a median follow-up of close to 20 months. So you can see the differences here in atrial fibrillation or flutter, hypertension, and hemorrhage. All were higher incidence with ibrutinib. This slide also includes neutropenia because there was a over double rate of neutropenia seen with zanubrutinib in this trial than was seen with ibrutinib. Looking at rate of treatment discontinuation because of adverse events, lower in this than the other trials, although a little bit shorter median follow-up than both of the others. 4% of patients discontinued zanubrutinib and 9% of patients discontinued ibrutinib. So looking at safety in sequencing, so we know that if patients stop responding to a covalent BTK inhibitor, that treating them with another covalent BTK inhibitor doesn't work. As Toby discussed, treating them with a non-covalent BTK inhibitor appears to be efficacious in about half of the patients, but switching from covalent to covalent due to progression is not effective. However, we have seen some data sets that have looked at patients who have gone off one BTK inhibitor due to toxicity or intolerance and then been treated with a second covalent BTK inhibitor. So again, the majority of these patients are CLL. We have some data with pirtobrutinib and mantle cell lymphoma. But in CLL, this shows patients who went off ibrutinib due to intolerance and then sequenced to acalabrutinib. Of 41 patients, 60 patients were treated on this. As you can see, most toxicities of interest, atrial fibrillation, diarrhea, rash, bleeding, and arthralgia. 41 patients of those 60 went off ibrutinib due to those toxicities and were treated with acalabrutinib. So 24, a little over half, re-experienced toxicity, but the majority of those occurred at either a lower grade and a few occurred at the same grade. And you can see there was a lower incidence of atrial fibrillation. Similar data set with zanubrutinib, so looking at patients who received zanubrutinib after going off of ibrutinib and a small number going off of acalabrutinib due to intolerance. And for the majority of patients who switched due to intolerance here, the toxicity did not recur, so 70% of patients with ibrutinib and 83% of those for acalabrutinib did not have recurrence with zanubrutinib. And then there were a small number that recurred at a lower grade and a few that occurred at the same grade. And then last is the data from the Bruin trial. So this is just in general toxicity of pirtobrutinib. So as we've talked, this is a more selective BTK inhibitor. So this shows toxicity of all patients treated, 725 patients. Most common toxicities, fatigue, diarrhea, neutropenia. And then AEs of special interest are listed. You can see any grade atrial fibrillation and flutter occurred at 2.6%. With 1 grade 3 or higher, hypertension at close to 10%, hemorrhage or hematoma at close to 10%. The median time for patients treated in the overall population was 8 months, and the discontinuation rate in this trial due to toxicity was only 2%, with an additional 5% of patients receiving dose reduction due to toxicity. This, again, is the entire population. As Toby mentioned, this was majority CLL, but also included some other B-cell malignancies and a cohort of 124 patients with mantle cell lymphoma. But the toxicities across the patients with mantle cell lymphoma were similar to the toxicities seen in the entire cohort of patients. So it did appear to be representative. Now, the Bruin trial, the majority of patients, as was mentioned, had received prior BTK inhibitor. Some of them went off for intolerance, while the majority went off for progression on covalent BTK. There was a small number who went off for intolerance. And this shows patients discontinuing that due to toxicity, with the majority of them having no recurrence of the toxicity or recurrence occurring at a lower grade, with very few occurring with grade 3 or higher, suggesting that, these patients, if they switch BTK inhibitor due to intolerance to one, that's a potential therapeutic avenue. So looking at overall, just kind of summarizing the experience to date with the BTK inhibitors, particularly some of the selected toxicities. So what have we learned? We've learned that not to give BTK inhibitors concomitantly with warfarin in the initial trials. It did seem that some of the major hemorrhages correlated with the use of warfarin in addition to the BTK inhibitors. For those patients who develop new onset atrial fibrillation, you would typically manage this like you would a patient not on BTK and try to treat them, manage them with rate control, and consider if they need anticoagulation based on CHAD score, consider non-warfarin anticoagulation with close monitoring. For patients who have recurrent atrial fibrillation despite medical management, that's when you would consider potentially switching to a different BTK. Hypertension, when this occurs, manage with antihypertensives like you would hypertension off of BTK. But again, if this becomes uncontrolled with, despite good medical management, then consideration of potential dose reductions or transition to an alternative BTK. We talked about atrial fibrillation and cardiac arrhythmias treatment. Monitor for patients for signs of bleeding. Most of these agents, it's recommended that if patients are going to have a procedure, that the agent is held both pre and post major or minor procedure for a particular number of days. Monitor for infections and secondary malignancies. Headache is a toxicity seen with acalabrutinib. Oftentimes, in my experience, this occurs for patients during the first month of treatment and then will disappear with time. This can typically be managed like you manage other headaches with over-the-counter analgesics and is also responsive to caffeine. And then, as was mentioned in the data looking at the randomized data, zanubrutinib does appear to cause a higher rate of neutropenia, and dose interruption and then dose reductions are considered for this, and growth factor support can be used as well. Now let's kind of transition from the BTK inhibitors to safety experience with immunotherapy, which Toby did touch on a little bit. So first of all, the chimeric antigen receptor T-cell therapy. Brexucell, while very effective in relapsed refractory mantle cell lymphoma, does not come without toxicity. So toxicity unique to CAR T-cell, which we see in other diseases as well, such as the CAR Ts used in diffuse large B-cell lymphoma, cytokine release or CRS, and neurotoxicity or immune effector cell-associated neurological symptoms have been reported with these agents. So this slide actually looks at results of CRS and neurotoxicity reported in the ZUMA-2 trial, but also in a cohort of patients treated after post-approval, the majority of who would not met indication for the eligibility for the ZUMA trial. So as you can see, toxicity was very similar, all grade toxicity, so neurological events occurred in a little over 60% of patients in both this real-world data set and in the clinical trial, with CRS occurring in 90% of patients. Looking at grade 3 or higher CRS, that occurred in 8% of patients, and neurological toxicity in a third of patients, as Toby mentioned. Neurological toxicity was the same in ZUMA-2, a little bit higher CRS in ZUMA-2, but there was a higher use of tocilizumab and steroids for management in the real-world population. So while CRS and ICANS are unique toxicities to these immunotherapy agents, the other toxicities that we've seen with this of concern, so cytopenias, there's a significant number of patients who can develop prolonged cytopenias, infections, and hypogammaglobulinemia, post-CAR T-cell therapy. As you can see, the non-relapse mortality was 9.1% at 1 year, and this was primarily due to infectious toxicity. And then the bispecific therapy, so as Toby had mentioned, this looks to be very effective in relapsed refractory mantle cell lymphoma. While we don't have the numbers or the follow-up that we've seen with CAR T, what we have seen looks to have very similar overall response and complete response rate to that of the CAR T cell therapy, although it does seem that this comes with an improved safety profile. So in the study that he discussed looking at glofitamab in relapsed refractory mantle cell lymphoma, CRS was the most common toxicity, occurring in about 3/4 of patients, but these were mostly low grade, with by far being most of them being grade 1 or grade 1 to 2. It is notable, as he mentioned, that while the follow-up is short, during that short follow-up period, there have been 4 COVID-related deaths, something that we've dealt with, unfortunately, over the last few years with a number of different therapies. But this is, I think, important to note. And I think now we have some cases to discuss.
So we thought you have now seen really a very comprehensive overview of all the data we are aware of about BTKI in mantle cell lymphoma. So we thought we bring that now to real life. So we prepared a couple of cases where we can really discuss the details of this. And here we are. This is a 60-year-old gentleman with a confirmed diagnosis of mantle cell lymphoma stage 4, which is the most frequent stage in mantle cell lymphoma. He presented with weight loss, fatigue, and splenomegaly. He has an intermediate MIPI score and performance status of 1. So based on that presentation, what would you prefer as the treatment for this gentleman? Maybe ladies first.
So I think, for this gentleman, it would be nice to know a few more things, maybe morphology, TP53 mutation.
P53 mutation was not analyzed because that was before the guidelines. And it was evaluated as a strange classical mantle cell lymphoma. I mean, this is real life,
This is real life. So, historically, my approach to a patient like this would have been to discuss some sort of cytarabine-based induction therapy, followed by autologous stem cell transplant, followed by rituximab maintenance. I do think that the results of the Triangle study, as so nicely presented by you, have challenged this thought and really led to a discussion with the patients of that is historically where we've seen potentially the best progression-free survival in mantle cell lymphoma, but we can potentially use BTK inhibitor in this with combined chemoimmunotherapy and have favorable outcomes, but with a better toxicity profile. The challenge, like everything we do, of course, comes in the logistics and the insurance approval of that. And so I think we're a little bit in the U.S. currently. We don't have approval for frontline BTK inhibitors, but as you saw, it has made it into the guidelines. And so that has can allow us at least an argument for such.
Mm-hmm. Toby, what would you go for? I mean, you're living in a country where FCR was being tested for a long time as first-line treatment. So what would be, let's say, bendamustine rituximab plus BTKI an alternative?
Yeah, I mean, I think at the moment, I would, similar to Cami, I would still use cytarabine rituximab-based induction autologous transplant. I'd like to drop that as soon as a BTK inhibitor becomes sort of routinely available. And then rituximab maintenance is clearly important here. If I had ibrutinib based on the Triangle results, I would drop the transplant tomorrow. So that's sort of my view. I'm very interested to see the results of ECHO. I think clearly we're not going to access ibrutinib based on the SHINE results, but be very important to see the results of ECHO because if the toxicity and survival kind of trade-off is more favorable, then it may be that becomes a sort of standard option in potentially in a patient like this in the future. So yeah, for now, still a sort of standard induction, but if I had a BTK inhibitor, I'd use it to drop the autologous transplant.
But Toby, I think in Great Britain you had this special deal, at least during COVID, that you could use BTKI.
Yeah, we did. It was interesting. So NHS England funded an off-license medication for a couple of years. So ibrutinib plus or minus rituximab actually was very, very popular during the sort of depths of the pandemic. So there's actually some data, I think, at EHA. So do take a look. There's 150 cases we've got data on, suggesting in lower risk patients it looks very active. Perhaps in higher risk patients it's not enough. So yeah, take a look.
Mm-hmm. So another question here is, what about the long-term follow-up of cytarabine followed by an autologous transplant? Can we cure at least part of the patients? That was at least formulated like that by Olivier Hermine, the first author of the MCL younger trial. After a 10-year follow-up, we are almost doubling the number of patients being in constant remission or ongoing remission up to almost 50%. So if you draw the line further, some of these patients won't be treated anymore for relapse. But as we have this gentleman now, if your health system would allow to apply BTKI in first line, what would be the hint really to the subset of patients who especially profit of this approach?
Shall I go first? Well, I think that's a very open question actually at the moment. Which patients can adequately receive, for example, CD20 plus BTK by themselves, and which patients require some sort of triplet, either with another novel agent, so like venetoclax, or with chemotherapy, because I don't think mantle cell lymphoma is going to quite follow CLL in that we're going to be chemo-free quite as rapidly. I think there's still going to be patients that will benefit from immunochemotherapy plus a BTK inhibitor. Who those patients are, it's unclear. I think what is clear from the data that we do have so far is that, as I just mentioned, CD20 plus a BTK probably doesn't provide durable disease control in high-risk patients, so blastoid, P53, probably high MIPI, etc. So it may be that we need to probably see risk-adapted studies a little bit more, not treat mantle cell lymphoma like a single entity, and I'm sure we'll see that more and more.
Mm-hmm. Anything to add?
I mean, no, I would agree with that, but I think looking at, the data, that if I had the option to use it now, anybody that I would offer more intensive chemo to, I would be willing to add the BTK and, forego the transplant as well. So I think, from what we know, patients that we're going to treat like that, so outside of the TP53 patients, I think, benefit from the addition of the BTK.
Okay, so here we are. Oops, sorry. These are the conclusions essentially for this, well, according to my age, I would say medium age gentleman. There are multiple options you could consider, and I think what we didn't touch so far, it's really, your individualized treatment of the patient performance status, the risk factors of the disease as you were trying to figure out, and of course, according to your health system. It's fair to say that so far we have these phase 3 results for ibrutinib with 2 different combinations, chemotherapy combinations, but we are eagerly waiting for the final data of the other second generation BTKI. Now let's make Patrick 14 years older. And otherwise, little is changing. So now we're talking about a 74-old chap. He's reasonable well. He's exercising regularly every day, 30 minutes, but exercising means for him walking around in his neighborhood. And so would that change your approach in this patient in any way?
I mean, I think so. Ideally, this is the kind of patient that I'm going to get on a clinical trial with a non-chemo backbone or combination. I think, options for this patient, we don't, again, have approval of a frontline BTK inhibitor in the US, but it is in the guidelines, so you can use potentially rituximab plus BTK, or we even have some data on rituximab and lenalidomide in this setting. I think getting the patient on a trial with, BTK doublet or triplet would be of high interest, and that's what I would really encourage a patient to do if I had the availability of such. I think in a patient like this, treating them with a less aggressive chemo backbone is reasonable. We frequently use bendamustine, rituximab in this situation, and I think that that's perfectly appropriate here as well.
Yeah, I'd agree. I mean, I think outside of clinical trials, we're still using immunochemotherapy as standard of care in this group. We're waiting for studies like the enriched studies you mentioned, Martin, sort of comparison studies in these kind of patient populations. But yeah, BR with or without maintenance, and or maybe even R-CHOP plus maintenance, still very effective in certain patients. So those would be the options I would use outside of clinical trials. But I agree. I mean, if you've got active novel agent combinations, then of course in relevant patients I'd like to use that as well.
So that's interesting. What drives your pick towards either bendamustine or CHOP as a chemotherapy backbone?
It's a good question. I think we don't have a lot. We don't have head-to-head data of those agents in mantle cell lymphoma with maintenance in both arms. We know that the European Mantle Cell Lymphoma Network study for R-CHOP followed by rituximab maintenance, actually median PFS is over 5.5 years. It's reasonable. So I would use some patient factors, comorbidities, etc., to determine which one of those I use. But I tend to use a little bit more bendamustine than I do R-CHOP.
And what about VR-CHP, at least in Europe? It's registered. I don't know, in US similar?
Yes, similar in the US. And I was going to say that would be another option potentially. I agree there isn't great data to push you one way or other, but maybe in a patient who, had aggressive disease behavior, high Ki-67, maybe you would take that approach with chemo.
So there are also questions in the chat. So it's not that easy to combine ibrutinib or any other BTKI with whatever chemotherapy. So our French colleagues performed the Biblios trial, which was a phase 1/2 study, combination of R-DHAP plus ibrutinib, and that was stopped early because of cutaneous toxicities, also thrombocytopenia. So for the time being, you only have clinical experience for the combination with either R-CHOP or with BR, just to mention that. Me personally, let's say if I have a case with blastoid mantle cell lymphoma Ki-67, let's say around 45%, I would not go for bendamustine, I have to be honest. But here's the question from the chat. I'm really very concerned with the use of Benda in mantle cell lymphoma, since Benda is an enemy of T cell and can cause T cell depletion and consequently affecting the success rate of CAR T cell. So my question is, do you consider that? I'm out because I'm saying, well, I don't use Bendam in the high-risk patients, right? So it's your question.
Yeah, I mean, I think it's a really important question. I think we need more data, certainly. I mean, we are seeing signals of differences in T-cell expansion and potentially efficacy in patients who've received very recent bendamustine, so within 6 months, some series, within 12 months, others. I mean, you've got to remember that most patients will have a reasonable response and duration of response following frontline, and then most places around the world, you've got to have exposure to covalent BTK inhibitor before CAR T as well. So most people will gain, at least 6 months as a minimum from covalent BTK inhibitor. So based on that, it's quite unlikely that a lot of patients would have relapsed and be CAR T cell eligible within a really short period of time. I do appreciate there are cases where that can occur. But of course, the trade-off there is it's a highly effective regime and it's been used as a sort of standard of care arm in lots of clinical trials over recent times. So I would still use it, but if I had somebody who had a TP53 mutation in the frontline setting and I knew about it, I probably would avoid it, because we know from the cohort in SHINE that their median PFS is under a year, and BTK inhibitors median PFS in that setting is about 4 or 5 months. So, well, at least ibrutinib. So I think, avoiding bendamustine frontline there, I think might be appropriate, but I think that's still very much open to debate.
Mm-hmm. So I would like to wrap up this part of the discussion that, in fact, in this patient, the individualized treatment options become different, because we don't want to harm our patients. And so far, the data sets we have The one set out is the SHINE trial, but similar study is now going on with ECHO and the head-to-head comparison, which is really proving the principle of a non-chemo approach, the Mangrove and Rich. We're eagerly waiting for the results. Now, to move on that, let's say we have one patient from Kemi's institution, that's Susan. And Susan is 70 years of age. She had at initial presentation a Ki67 of 40%, which means high risk, and therefore Kemi decided to enroll her in a clinical trial with a covalent BTKI plus R. And important for this setting, the BTKI is continuous until progression. Now, Susan is 74 years, so I would say for a case with Ki67 of 40%, that's a success, a 4-year remission. And she again presents with weight loss and abdominal pain. And PET-CT shows a progressive disease in both the thoracic and abdominal region. So, Kemi, as this is your patient, what are you doing now?
Yeah, so I think the first thing I'm going to do, Susan's 74, so I'm probably going to just assess if I think she's a candidate for CAR, and I'm going to try to get her to CAR if she is a candidate for such. I think if I have a trial looking at a bispecific antibody or bispecific antibody combination, that would be really great. But off trial, I'm going to try to get her to CAR if she's a candidate for that. Most likely, it sounds like from her symptoms and disease, she's going to need some sort of bridging therapy to that CAR and is probably not going to get to it without. So I'm probably going to try to transition her to a non-covalent BTK with pirtobrutinib, which we now have available, collect her and take her for CAR. I think, there's also the potential to bridge her with something like steroids or radiation, but if I could get away with that, that would also be a potential option. If she's not a candidate for CAR, I think that the best data we have outside of, bispecific trial is the non-covalent BTK, pirtobrutinib in these BTK progressors.
So there's explicitly questions for you, which is for CAR T cells. Is that easily available in US?
So easily available, kind of. I think that's a hard question. I mean, the patients have to be able to, at my center, yes, but I'm in an area where not everybody wants to, come to the center, or not everybody has the resources. There are intense resources, especially after the CAR, that patients need to have family support and the ability to do so. So I would say, if somebody desires that, we can get them through that. There isn't really an age cutoff for CAR per se. We've done patients, I think I forget, 80 something was the highest in the cohort of patients that was reported in the real world data. But there certainly is the toxicities are real and they have to be considered.
Yeah, I agree. I think the question is CAR fit or not, or suitable, I should say, or not. We may be faced with quite an interesting scenario in Europe and the US fairly soon if pirtobrutinib is approved in Europe, because the approval might be actually slightly broader than the US approval, and the reverse is true for CAR T. You can use CAR T in the US second line, whereas in Europe we can't. So with sort of my UK European hat on, maybe this, for example, pirtobrutinib is available second line in the future, and actually she might be a good candidate for that. Having said that, she's chemotherapy naive, I think. So going back to something like kind of R-CHOP or R-CHOP with cytarabine or something prior to then thinking about CAR T third line might be a reasonable option as well. We don't have any data on chemotherapy second line after covalent BTK front line, and we need to kind of understand its role there as well, I think.
There are these fabulous, in fact, RBAC data with a response rate of more than 80% in the setting. So what would be your favorite bridging to CAR T cells? Because normally these are rapidly progressive.
Yeah, absolutely. So I think it depends how quickly you can apheresis cells, and whether if you can do that quickly and then using potentially RBAC. feel a little bit nervous in the 74-year-old to do that. It's quite a punchy regime, and you might have to dose attenuate. But it is potentially an option. If they're Ara-C and bendamustine naive, it's highly effective.
And then one question too concerning the data you presented concerning pirtobrutinib. The question is, did the results differ on the kind of covalent BTKI being applied previously? This is a very knowledgeable question.
It's a good question. To my knowledge, the vast majority of patients had received ibrutinib previously. There are very few that were acalabrutinib, zanubrutinib. So in terms of a detailed breakdown according to prior covalent BTK, we haven't seen that, and there aren't many patients that didn't have ibrutinib. So I don't think we'll have that data from the first part of Bruin.
Okay, I think this patient shows that it will become much more complicated concerning the therapeutic algorithm, the sequential treatment with a new first-line treatment. What we can conclude, another covalent BTKI, you have not heard about that, and the reason is the resistance mechanisms for ibrutinib are relevant as well for at least the second generation BTKI, so it does not make sense to move from one to another. We have the broader option and the broader approval in US, and the non-covalent are also approved in US. So you're living in the paradise, Kemi. So which patients you would refer to right away going for CAR T cells? What would be your trigger? You said fitness, but would you all fit patient then move on to CAR T cells, or in second line now in this scenario?
I mean, no, so I would say that still I standardly use a BTK inhibitor in the second line. The patients that I'm really thinking about, they need a CAR. Those patients with TP53, high Ki67, blastoid disease, they don't do as well with BTK inhibitors alone. And we know that at least in the numbers in the Zuma trial, they look like they have, similar responses as the efficacy population to CAR T cell. So those patients, I mean, I'm still bridging them, but I'm prescribing a BTK and getting them ready to go to CAR.
Mm-hmm. And last question, which I think is very challenging. How would the detection of a P53 mutation drive your decision in any way?
In the frontline setting?
In this patient.
Okay, I mean, if it was picked up in relapse, so at biopsy at relapse, then I think that would trigger getting to CAR T probably as quickly as possible. Although, of course, some of the real world data doesn't look quite so promising in terms of progression-free survival with P53 mutation deletion. The initial responses from the pirtobrutinib study look good. They look fairly equivalent, but obviously not a lot of patients again. So concluding too much from that subgroup's a bit difficult. But I think I'd be aiming for CAR.
I fully agree. So P53 mutations are really the red traffic light. Then you have to speed up. Please have a look at our suggestive algorithm, and then we have another poll to check whether you have. No, just kidding. This is what you can make up, and then I think it's very fair to say we don't treat all patients. The same might it be for the patient's fitness, and might it be also for the disease, the underlying disease itself. And in relapse, in future time it will become even more complex in that way that we have to differentiate between prior BTKI use, yes and no, and then the next complex or situation is what are we doing in these patients after fixed duration BTKI when relapse is occurring rather late or early. So life becomes more complicated for our patients, but also options are becoming more various. And I think that's the best we can hope for in the interest of our patients.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/YEK860. This activity is supported by an independent educational grant from AstraZeneca.